quick announcements. So welcome everybody to our lunchtime Stanford Medicine Center for Improvement lecture series. I'm Laura Holdsworth, again from the Evaluation Sciences Unit in the Department of Medicine, and I'm very excited to facilitate today's lecture with Kandice Garcia Tomkins. But before we get to the lecture, I just want to say that our next lecture will be on July 11th with Theodore Grancherov, and I think with the title to follow, so stay tuned for more information about that presentation. And as well, if you saw it flashing around, there's the Lean conference in October, and right now with early bird pricing. So make sure you sign up for that conference. Anything else from Selena or Lisa before we get to today's presentation?
Not for me.
Okay. Great. So today's speaker is Kandice Garcia Tomkins, who's one of our own quality improvement experts here at Stanford, who has helped to develop some of our very successful improvement programs, such as RITE and ACIS, that you might be familiar with. Kandice is a radiology nurse by background and has been working as a quality manager for the last 9 years. She's currently working with the American College of Radiology on the program she's going to talk about today, which I'm very excited about. Which has been to create a network of learning collaboratives to improve a number of practices in the field of radiology. And as usual, if you have any questions, go ahead and put them in the chat, which I'll be monitoring. And I didn't check with you, Kandice, but is it okay to interrupt you if there's any clarifying questions as we go, or should we save them all to the end?
Nope, just jump right in anytime.
Okay.
It's totally fun.
Okay, great. So I'll monitor the chat for that. Otherwise, we'll hold questions for the end. We'll aim for about sort of 30 minutes of lecture with questions at the end for about 10 minutes. And we'll kind of wrap up by about 10 minutes to the hour. And with that, I will hand over to you, Kandice. Take us away.
All right. Thanks so much. Well, welcome, everyone. I'm so glad you're able to make it today. Talking about improvement is one of my absolute favorite things to do. So I'm really looking forward to sharing the work that I've been doing over the past couple years. And really, it's the culmination of work I've done over the past decade. So let me kind of switch my displays here. I'm going to talk about the ACR Learning Network today. The ACR is the American College of Radiology, which is a professional organization for physicians, radiologists specifically. And they have a lot of different things that they do. So they create quality measures for radiology. They create clinical standards, registries. If you're going to get equipment signed off, to be able to take mammograms, you have to have accreditation for the things that you do. So ACR encompasses a lot of different entities to support radiologists and the work that happens within the radiology departments across the country. They have an entity in their organization called Quality and Safety, and this includes registries, best practices, measures, things like lung cancer screening, like I said, accreditation. And one thing that they've always really wanted to do is have a focus on improvement and supporting organizations and getting better. So over the past couple years, the ACR has really started to look into how they can do this. Today, I am going to talk about quality improvement just a little bit in general to give us a little lay of the land of how this came to be. Then I'm going to really dive into the ACR Learning Network and then a little bit about what we're learning, because I think most of you are dabbling in quality improvement in massive quality improvement roles. So you guys are kind of my people, and we can talk about this is really all about learning and iterating and making ourselves better. And so that's a really big focus for what we're doing in the network as well. So I was a radiology nurse by trade. I got into my first role in an organization that did not have a standard onboarding process. They basically were like, hey, welcome, you should do some work. And I was like, I'm a new grad. How about I write everything down that you teach me? And so I just started writing things down. So I have this nature to document things, make things better, have standard processes. I love order and rules. And that's just who I've been as a person my entire life. So when I came into nursing as a second career, it really spoke to me to want to put everything in neat little piles. Turns out that's a lot of quality improvement, just kind of organizing things. So I fell into a part-time quality role in the department that I was working in, where I got introduced to Lean. And I didn't really quite get it. Now that I think back, I'm I didn't get it at all. But then I was really inspired by it. And I was like, I can do this. Like, okay, like Kaizen events and like process owners. Okay, I get it. Visibility boards. And I really, really enjoyed kind of like the structure and framework. And I didn't realize like before I got into this role that like there was a science around this, and there were like things that you can do to make things better for lots of people. And so here I am thinking I'm a great quality person, and a full-time role comes up at Stanford to be the quality manager in the radiology department. I'm like, this is for me. I think I can do it. And then I met Dr. David Larson. I don't know if you guys know him. I think a lot of you do. And I fell into a place, I think back now, and I brought him this portfolio of work that I had done, and he must have just looked at it and went, you don't know what you're doing. But he took a chance on me and he hired me anyway. And since then, that was about 10 years ago now, David and I have worked to create multiple programs. Basically, David has a vision for quality improvement. We developed RITE. That was the first program with our team in radiology. So myself, David, and Jake. And we were able to create a standard process for improvement while also getting projects done. Over the years, it has been iterated on. And in, gosh, what was 2008, a lot of my work started to figure out, how do we spread RITE? How do we create a platform based on these principles that other organizations can use? So I started working on grants to kind of spread that platform. COVID hit in 2020, and we had no choice but to go online. And it was probably the best thing that ever happened to our vision for what we could do for other hospitals using this type of format. It forced us to go online. It forced us to create an environment where improvement could happen collectively, not within the same organization. And since then, I believe it was about, 3 years ago, David became the chair of the Quality and Safety Commission at he became the chair of the ACR Quality Commission on Quality and Safety. And with our executive vice president of quality and safety at the ACR, Trey Chatfield, they applied for a grant through the Gordon and Betty Moore Foundation to create learning networks. So what we know about problems in healthcare, I think you all experience, is that they're everywhere. Not only are they everywhere, but they're not unique to an organization. So what you see in one radiology department is typically what you're going to see in another radiology department, right? Our processes are not that good. Like, wait times are long. It's really hard to get an MRI scan. It's really hard to manage patients for walk-in x-rays. Like, we notice that across organizations, we're all dealing with the same kind of problems. But what isn't the same is the way the organization functions, the way the organization is designed, the way that it does things, the way that problems are going to be solved is not the same. But what we recognize is that there are a lot of things that I do here at my organization that you do at your organization that we could learn from each other. And if we just kind of came together to solve these problems at the same time in the same way, we could actually make huge gains, not only for our own organization, but for like radiology in general. So that's really what the Learning Network is for. The Learning Network is a program supporting multiple collaboratives. So so far, we've selected 4 different issues that we focus on, where organizations come together to solve the problems at the same time, in the same way, at the same pace. What we found is that collaboration doesn't just happen, right? If you're all just like, okay, we all want to make mammography positioning better, we're all going to do it. It actually is really hard to be like, this is what I'm doing, this is what you're doing, this is what worked for me. It's more of just kind of like this storytelling, and like, it's like, okay, very nice, but that's not going to work for us. Or, okay, that worked for you, but like, how am I supposed to do that here? The actual application of somebody else's solutions doesn't actually transfer that well. So what we found is that you actually need a common process for improvement. So the same way with a common language, and if I'm talking about my current state analysis or a key driver or something that has to do with the process, like, we all need to be like speaking the same language. We need a universal measure. So I can't just say like, I'm good at this. Like, you have to have a way to measure your performance, and that has to be the same across all of the organizations. So everybody has to buy into, this is what good means, and this is how we're going to know what that is. And then the last thing is, you have to have a place where collaboration and those conversations can happen. So as much as I'd like to say, I'm going to reach out to organizations and learn from them, unless you have a place and a time and a real direction for that conversation, it doesn't just happen. So what we want to do with the network is we want to bring organizations together to create that environment where we can learn from one another, where we can support one another, and we can really push the boundaries of what is possible for radiology. So our 4 improvement collaboratives are mammography positioning, prostate MR image quality, lung cancer screening, and recommendations follow-up. So our approach really is, it's a relatively highly structured and centrally managed. So this isn't like ad hoc. If anybody's participating, you're like in, like you sign up and you're with us for, it's not exactly a year. Our program has changed. We started with a 9-month program, and then the cohort number 2, we're doing a 6-month program. Like I said, we're applying our concepts of quality improvement to the development of our program as well. When we started the grant, we started out with nothing. Basically, that group of 5 people, Dr. Larson, Maitre, myself, and Judy Burleson and Kay Zacharias Andrews. And we said, okay, what are we going to do? How are we going to do it? And we started from the ground zero and said, okay, let's put these things in place. Let's see how it goes. So every cohort, we're iterating and refining and making things better and really trying to hit the needs of what we're trying to do. Our program, the Learning Network, begins with an intense training and project support, and project support along with education, training, and coaching. So this is unique to our Learning Network. There are many, many learning networks out there that are popping up. It is really the future of collaboration and problem solving across organizations, but ours is very structured for improvement. We really have a huge emphasis on the way that things get better. And then, of course, measured, deliberate program expansion. Everybody is to get better, but also make their own organizations better. So using the tools across their own organizations in the future, and then disseminating improvement methods throughout the field. Our vision really is that this is the way radiology gets better. And so the ACR has taken the lead in housing that philosophy. So our version of the improvement program is called Empower. And this is very similar to RITE. So it's foundationally similar to RITE. We use a lot of the same constructs, a lot of the same principles, but they are iterated on for this type of environment. So for example, we are a team-based, project-based, multidisciplinary program, very similar. If you're coming, you're bringing a team, you're not doing this on your own. There's a project that you need to work on alongside. It's not just about learning improvement. It's also about applying improvement concepts right when you learn them. So very, very similar. But what we do differently is every cohort, we know more. So when we go into cohort 2, we already had an idea of what a current state analysis should include. We know what the measure is going to be. So we do a lot of measure development like prior to the program even starting. We have an idea of what key drivers people have already selected. So we already have an understanding of what each of these entities will take. We don't just give those to people, but we guide them through them, and we have something to go off of. So it's a little bit more of like guided improvement, which is a little bit different. And I'll talk about some of the similarities and difference for those of you know. So the goal of the Learning Network is actually to improve diagnostic excellence with a focus on cancer. So that's really where the grant came from the Entity of Cancer Research and Support. But our 4 main goals are to teach a structured process for improvement, demonstrate local improvement, so get projects done, develop improvement-driven measures, and foster collaboration. So in order to do this, we have a very large team of people. We have our 5 strategy, our people on the strategy team, but then we have a bunch of different roles that support each of the collaboratives. So our collaborative leaders are physicians or radiologists from across the country who have a specialty in the collaborative that they're supporting. So Dr. Ben Wonky from URMC and recommendations follow-up, Neville Irani from University of Kansas and lung cancer screening. We have Dr. Sarah Pittman, who's actually here from Stanford. And then Dr. Andre Parisco from the Cleveland Clinic, who focuses on prostate MRI. These are our kind of physician partners. They're our content experts, and they really lead all of the physician to physician conversations. We do a lot of clinical decision-making type improvements as well. So it's really important that we have a physician leader to kind of guide that, as well as these are experts in each of these areas. And so they're really great resources for other people to kind of connect who's done what, what's best practice. They really kind of help bring that to the group. Every cohort needs administrative leaders. So I'm the QI lead. So I do all of the quality improvement, leadership, education, development, supporting all of the coaches trainings. And then my partner, Kay Zacharias Andrews, she handles all of the administrative stuff. So we started from nothing. And so she is building the structure, the framework, everything that you would need for a program to function at this scale. And so she manages all of that at the ACR. And then she and I together, walk blindly into the future, developing things and communicating and collaborating, trying to make things better for our for our participants from each side of the coin. Quality improvement, getting people to actually learn in quality and do good work. And then also from her side, which is making sure that they have everything that they need to do that. And then we have a very unique role called our learning facilitators. And these are people from the ACR staff who have a specialty in the content area. So we have 2 for mammography, 2 for prostate, 2 for recommendations, 2 for lung cancer screening. And what they do is they take best practices and they bring them from year to year. So for somebody who has a good idea, who has tested it and validated it, they're able to spread that to future cohorts so people aren't always reinventing the wheel, as well as collecting resources from the ACR. So one of the things we recognize is that the ACR has a ton of resources for radiology departments to use, but it's not always easy to access them or find them, or when working on a specific key driver to match them with that intervention with your key driver. So these learning facilitators really put those together, as well as connecting organizations with like-minded goals or like-minded problems. And they're really there to facilitate the peer-to-peer learning. So from this large group, we're able to support all of our teams going through the program. Now, it starts with an application. So this is where we figured out, what are the keys to success? Like, what are we really looking for in an applicant? Can anybody join this program? And what we realized is no, this is a huge commitment. We're asking a lot from organizations when they're participating. So they need department leaders who are supportive and willing to manage change, a team of engaged frontline staff, including a physician leader, to participate in the program and do project work. They need an improvement coach with QI experience. So everybody has to bring their own QI person to lead their team. They need to commit to the 6-month training program and report data weekly. And sometimes that requires image auditing or report auditing. So it's not just pull this data, send it in. It can be really, really manual process. And then they need organizational sponsors to provide resources for the project. So making sure everybody has the time that they need and the availability to do the things that we're asking them to do. And then, of course, you have to want to collaborate with others. This isn't an independent journey where you're going to go on. This is all of us working together, supporting one another and learning from one another. So when we find applicants who kind of meet this criteria, we have conversations with them. It's also very labor intensive. We have an interview process, and then we kind of rate them on this scale. We have large conversations with our collaborative leaders, and together we'll extend an invitation to an organization. Now, the program then doesn't just start. We have about 2 months of what we call program preparation, because what we found is that preparing a project for a program like this or an improvement project at all takes a lot of preparation. So we have a project charter that needs to be filled out, and those are all the decisions that need to be made on a project prior to it starting. And that's typically filled out by the project sponsor. The sponsor is the organizational leader who is there to support the project. And they're usually the decision maker. And we're saying, hey, decision maker, what's going to be involved? What's the scope of your project? Who's going to be on the team? Because we've done these collaboratives, we provide the problem statement, we provide the global aim, and we provide the collaborative measure. So it's really just you guys on board with that? Does that sound good kind of conversation? And then we all move forward with the same problem statement, the same measure, and the same global aim. Collecting baseline data prior to the program starting has been a huge benefit for us. So we do that. By the time the program starts, everybody is expected to have baseline data on a run chart. And that takes typically about 4 individual sessions, 4 one-hour sessions with each of the collaboratives to make that happen. The project team is then decided, and very similar to the structure that we have in RITE, the QI coach, the sponsor, team leader, physician leader, and team members. And we like to estimate, the time it will take to participate in a project. And I think this is the biggest challenge we have in communicating, because we say 4 to 6 hours a week for the duration of the project, but it seems like a lot right here, but when you actually get into it, it has to go his way. It seems like a lot when you're getting people off the line. You've got a team of maybe 6 staff. So these are really important conversations that we have to have about creating expectations about what we're going to do. And the QI coach, it turns out, is actually the most robust role on the team. They have the largest commitment with us because we actually provide extra training for QI coaches. What we found is that there's a couple different levels of improvement or improver in an organization. And those of you who went through ACIS, we'll talk, you guys know what I'm talking about here. We have our first order improvement, second and third order improvement. So first order improvement are people who are going to go through the Empower program and learn how to improve, participate on a project team, and do improvement, right? So now you kind of know what it is and you're going through it. Second order improvement are for our QI coaches. So there is more to know about improvement than just doing improvement, right? So if you're guiding improvement, you're bringing people through the application of concepts, that's another level of education. So through this program, our coaches get what we call second order improvement education as well. But that takes extra time and resources. So our QI coach is really committing to a lot when they participate with us, but they get a lot out of it as well. We bring our coaches from sometimes really inexperienced coaches, maybe never have run a project before, to pretty experienced coaches with a successful project under their belt. And I'll talk a little bit more about how we do that in just a little bit. So here are improvement-driven measures. Each of these measures have been developed by the collaboratives themselves. So the physician leaders, team leaders from each of the collaboratives have participated in the development of these outcome measures. For mammography positioning, it's the percentage of images that meet mammographic positioning criteria. We've created criteria that meet, and each image has to meet or not meet criteria. Now, this doesn't mean it's not diagnostic. So this is a very strict level of quality. This is more quality than you would need to actually do your job as a radiologist or read the exam. But what we've decided is that if this was my mammogram, I would want it to meet all of this criteria, because the more criteria you meet, the better chance you have of detecting cancer in my scan. So the group created a criteria or a level of quality that they would want for themselves. And that's how we came up with the criteria for that measure. Prostate MR image quality has, again, the percentage of exams that meet the requirements, but they're using another scale called PI-QUAL. And that is a 1 to 5 scale, and anything of 4 or 5 is excellent image quality. It also has a subset of another measure because we're still kind of developing it. There's a subset of it called DWI that is actually probably the most important part of the measure. And so we're trying to decide, is this do we need the entire measure? Can we just use this subset? So we're constantly iterating and testing and getting feedback and having discussions with our collaboratives and saying, what do you think? And having them weigh in so that we can come up with something that not only works, but meets our needs for improvement and also measures the outcome of their process in a way that is really valid. Lung cancer screening is using the percentage of lung cancer eligible patients being screened. Again, eligible patients is not clearly defined. It's not something that's been done before. So they're coming up with measures and testing different ways to understand what is possible for lung cancer screening programs. And their recommendations follow-up has 2 measures. This is something that's come up in the last year. We're looking at the appropriateness of the measure. So in recommendations follow-up, what happens is there is a lung nodule in an exam, maybe like a CT exam. And, the radiologist is reading it. Maybe it was like a broken clavicle. And you're looking at the exam and you're saying, oh, it's a broken clavicle, but ooh, I think there's something here. There's a lung nodule. This needs to be followed up on. This person needs to come back. This isn't what we would call an incidental finding or an actionable finding. So what we found is that for those actionable findings, the recommendations that the radiologists were making were not always appropriate. There's guidelines that should be followed and not everybody's following those guidelines. And then once the guideline is made, those patients, maybe only 30% of them are actually coming in for that exam. So we want to make sure that exams are appropriate, or the guidelines are appropriate, and that the patients come in for their exams. And that's really the focus of that collaborative. And those are the ways that we are measuring success. So what happens is everybody in the collaborative who has been selected does measure development meetings, getting baseline data, and then we start the program. So everybody kind of knows what their performance is going into day one. We have 10 learning sessions. Each learning session has specific content that is accurate, like just perfectly curated for where they are in their project. Now we've iterated on this content collection for about 10 years now. And what we have found is that every topic that we have for every different learning session is exactly what they need to know at that time. There's a few that are just a little ahead, a few a little behind, but what it is this window of what we call just-in-time learning. We don't want to give it to them too soon where they can't apply it directly to their project. And we don't want to give it to them too late where they're scrambling, trying to figure out what to do. And then we haven't provided the information. So each of the videos is a reverse classroom model. They watch videos before they come in, and then we have a discussion-based session where we talk about the information and do activities during the sessions. And at each of the sessions, it corresponds with a section of the A3 that they're focusing on. So we use A3 method to manage our projects. The A3 is our main tool for project communication, consensus building, and of course, project management. So the first half, sessions 1 through 4, are all about the left side of the A3, and sessions 5 through 9 are all about the right side of the A3. And it really is a nice framework for us to provide content and really give them an opportunity to do the things that we're teaching them right alongside of it. So in between learning sessions, the teams are expected to do homework. So we give them a lot of things to do. So between session 1, we're observing the process, we're finding the problem statement, collecting baseline data, we're starting the run charts. And then we have Walk the Wall, which is the project report outs where every other week they talk to us about the project so we can help guide them. At Walk the Wall, there's a couple things that we do. Number one, we want to make sure that everybody's on pace to keep up with the program. It's rigorous and it goes fast. So we want to make sure that they're on pace. Number two, we want to make sure that they're applying the concepts appropriately. This is the first time most people have done any of these things, and it's not exactly intuitive. So this is their opportunity to talk with us, the QI leader and the collaborative leaders, to make sure that they haven't missed anything, to everything is like kind of going according to what we expect. And then, how am I doing on time here? We're going fast. Okay. And then we give them feedback and keep them on pace. The way that we know that they're on pace is we use the project progress scale. And this is a way to say where they are in relation to where they should be. And by the end of the program, we expect every team to be at a 3.0. After the program is over, the teams then join the Learning Network. And this is where they have deepen their expertise. They continue to improve together, share best practices, validate what they've done, and continue to report data. The network is based on principles and commitment. So everybody is committing to working together, all teach, all learn, collaboration and not competition. We practice this throughout the program so that we have those skills when we join the network, so that we're able to continuously learn from each other over time. Participating in the network after the program is a commitment. So people need to continue to sustain improvement or continue their improvement. They need to report data monthly and join us in quarterly meetings to share their progress report out and let us know what's working, what's not working. And then they mentor the incoming cohorts. One benefit of participating in the Learning Network, though, is the ACR is going to be recognizing organizations who have outstanding performance. So if you are an organization who, let's say your image quality started at 30% of your images meeting criteria, but by the end of the cohort, you were able to get that up to 90%, which is not unheard of. We had many teams who have already had that kind of success. The ACR wants to recognize those organizations for having outstanding image quality so that across the board, we can not only help these organizations do better, but really promote those ones who have put in the time and effort. So it's a really great place, national platform for organizations. Now, training our QI coaches, like I said, their role is the most robust on the team because we have so many commitments that they can participate in, but they have to meet with us as the start. We get to know them, we establish a relationship, and then we have 5 coaches training, which are 2 hours over the course of the program. So they happen kind of around milestones in the program, but it's typically, you know, every 3 to 4 weeks, we have a coaches training, which is where we help them understand how to apply the concepts, what's coming up next, how they watch out for their teams. Then we've added QI coaching support, which is how to do the assignments. We recognize we had first-time coaches and we'd be like, go do a process map. And if you have an experienced coach, they're like, great, got it, see you in a couple of weeks. For our new coaches, they're like, whoa, what? How? So we now have sessions where we actually break down some of the actual tools, the activities. How do you facilitate idea generation? You know, how do you select the process measure? Some of those more like how-to activities, and those are optional for our coaches. We also provide peer coaching support. So if you're a new coach, you've never done this before, this last cohort, we are testing what that would look like to partner with an experienced coach. So we had a couple coaches who are partnering with organizations, and it's really working well to provide that support. And then this is the first time this cohort, we actually provided 2 full-time coaches for organizations who were not able to provide their resources. So we're testing out, can we provide an external coach to an organization and it still be successful? So far, it's going really well. Now, this is what happened. So our initial cohorts, cohort 1 happened from April of 2022 to November 22. We had 22 projects across the 4 collaboratives. In cohort 2, which we're currently in the middle of right now, we have 21 projects across the 4 collaboratives. So we had 15 for mammo, 10 for prostate, 11 for lung cancer screening, and 7 for recommendations follow-up. Mammo just happens to be really popular. It seems to be that mammography departments definitely want to do better, and they really, really love to join programs like this. We have a lot of interest for mammo. Recommendations follow-up being on the other side of the coin. Now, this is program development, and an organization has to have certain elements of their program already in place before they can participate with us. And since it's such a new initiative for a lot of organizations, it's actually really hard to find ones that already have programs in place. So that's why we have a little bit less engagement in that cohort. For cohort 3, we're just taking applications now. So for those of us who are running the program, there's a lot of overlap in the work that we do, and we're constantly working with cohort 1 in the network, working with cohort 2 in the program, and taking applications for cohort 3. Here are our cohort 1 results.
Sorry, yeah. There was just a question in the chat, I think, about the projects and whether the projects that you showed there per collaborative, I don't think add up to 21. So is it multiple projects?
This is across 2 cohorts. Okay. So this is across 2 cohorts. So this should be, if my math is correct, this should be 43 projects. And
it's correct that an organization can have be in multiple
more than one
right?
project.
So they can be have more than one project, right? Okay, great. That's the question.
Yeah, that's a great question. So we do have some organizations. We have like a radiology group who has multiple sites, all within the same collaborative. And then we have organizations who have joined multiple collaboratives. It's kind of like once they get in, they're like, this is great. Like, we kind of want to do this again. And then they figure out what collaborative they want to do next. So far, that's been a trend for a lot of organizations. How many organizations have gone through this? I'd have to do the numbers. It's probably 2/3 of the projects, because I would say there's a handful. I'd like 4 organizations or 5 organizations who have joined multiple collaboratives and done multiple projects. Okay, so on the project progress scale, this is what happened in cohort 1. We had 4 teams who who got to about a 4.0 by the time the program was over. So measures meeting goal with data meeting SBC criteria. We had 15 teams kind of in this middle range of they've met SBC criteria, but maybe not at goal yet, or they started seeing modest improvement in the right direction, but they weren't at goal yet. We had most of our teams fell in this middle area, which we were really happy with. That was kind of the goal of the program. And then we had 3 teams who were not able to meet that 3.0 criteria, and was really interesting. This was came out to a really nice bell curve, and this is what we were kind of expecting. But 86% of the teams had a really successful project. But I would say of the 3 teams that didn't meet the 3.0, still had a very positive experience with us and did a lot of learning throughout the cohort. And that's the feedback they provided for us as well. So we were pretty happy with cohort 1. Now, when we have collaborative level measures, I know I'm running out of time, Laura, I've got just a few more slides here. Okay, when we have collaborative level measures, we're able to aggregate the data. So this is one way we like to look at it, especially when we're de-identifying sites. We don't necessarily want to share everybody's individual improvement journey, but you get a general idea. In cohort 1, we definitely made improvement across the board in all 4 of the collaboratives. Now, I did de-identify some of this data so we could look at it, but when you look at each of the individual projects, some of them were really significant. So this is one for lung cancer screening that doubled their CT volume over the CT screening volume over the course of the program. Mammography positioning, we went from 55% or 57% to over 95% of their images meeting quality. This is recommendations follow-up. This organization, their appropriateness went from 40% of their recommendations being appropriate to 100% of their recommendations being appropriate. Now, for those of you who are in improvement, know what level of reliability solution requires. It is required for 100% of your exams to meet appropriateness. They did. They had a level 3 reliability, and it was very, very successful, as well as their percentage of follow-ups being completed. I mean, they basically were barely tracking it. It was down at like 10% of their recommendations being completed, and they were able to get that up to over 70% by the end of the cohort. And then, of course, prostate image quality. This was one of my favorite teams. Only about 10% of their images were meeting our quality standard, but by the end of the program, they were able to get up to 95% of their images meeting the quality standard. So it was really, really impactful individual journeys across the collaborative. Really positive feedback from everybody who participated. I know the RITE program has similar type of experience, but people really, really enjoyed working with other people. They created relationships across organizations, and they were able to make improvements in their program that were not only impactful for their patients, but the staff. What we realize is that we've got to teach people to see things that they can't see in improvement. This program is not just about improving, but it's about creating new shared vocabularies and mental models about the things that I don't even see, right? Like the systems, managing change, personalities, all of those things really impact whether my project is successful or not. And we like to teach people about that content and how to see your project, your team, and your improvement in a different lens. The second one is structure. Going from a stable environment through an unstable environment, when you change back to a stable environment, requires structure and framework. So the scaffolding is the timeline, the roles, the tools, the A3. It helps people know where they are as they're going through this chaotic time. And then the management, holding people accountable, validating their experience, helping them with the humility that it takes to face the problems that they're facing and actually make the change. That's really what we're here for. And then, of course, anytime you're doing a program, it is imperative that you apply the concept of improvement to the iteration of your program. We are constantly saying, this is working, this is not working. We need to do this a little bit better. Let's make this change, set in sand, set in stone. And for those of us who are developing programs and managing programs, it has to be part of the way that you run the program is you've got to improve, because we've got more coming. So in 2024, we're going to be adding another cohort, and then our goal in 2026 is to have 2 more collaboratives to join as well. So all of our collaboratives will keep running through the years with additional support for new problems in radiology. All right. Thank you guys so much. I'll check out the chat here and see if there's any questions.
Thank you. Thank you, Kandice. Thank you to everybody. Round of applause, virtual applause. Thank you. That was great. I was writing down questions, but it was fine that you went over because you ended up answering most of mine that I wrote down. So that works out well. And there are some questions in the chat, but as I'm facilitator, I get to the prerogative to ask my own question first, if that's okay. And what I'd like to ask, and you talked a lot about the structure of the network. You know, it's highly structured. There's a lot of time commitment. People have to have the sites have to have coaches and teams, and there's a lot that in that application process that sites have to come with. And you talked about, you know, in this latest cohort, 2 of the sites not having coaches, and so you're actually providing them. So there's questions around, I guess, future sustainability. You know, you providing that resource. And I'm just curious about, you know, looking here at this future work. And I wonder whether, you know, the organizations you're engaging with now are kind of have that resource to participate in this type of highly structured process. And of course, there's going to be a range of organizations out there that want to improve, but maybe don't have those kind of resources or capacity. And as you look forward, what are your thoughts in terms of the network of perhaps either engaging with those organizations that don't have as much capacity in their system? Like how many organizations are out there that are untouched that have that? At some point, you might kind of hit the ceiling on that, and there might be other organizations that you'd have to work with that are less resourced, but might require a slightly different approach. I don't know whether you guys have thought that far ahead or whether that's something that's occurred to you so far.
Yeah, that's the thought that keeps me up at night, actually. So that we think about that a lot. Yeah, no, it's true though. It's really hard. Quality improvement resources are not cheap. But they are absolutely integral. The application of quality improvement concepts is not easy. And especially when we're asking frontline staff, who are the ones that are our knowledge trees, they know really what it is. To be able to have them then take this quality improvement knowledge and be sophisticated about it and be able to apply it, it's really, really difficult to do. So we think about that, what about organizations who don't have quality improvement people? We're trying to provide resources, but again, it's very expensive to do that. And so I don't think it's a sustainable model. I think that's why we've really focused on the QI coaching support in a lot of different formats. What we've been able to do is provide support, a level of support for varying levels of quality improvement experience. So we have some people who have never done quality before, were maybe a manager in the area, and now they're like, well, I was the only one left, so I'm going to be the coach on the project. And we've been able to support them enough and give them enough education where they are able to support their team successfully. So we're kind of going through a couple different avenues on how we can support that resource. But your second question is really valid, is what if there's an organization who doesn't have the time? I know we're all going through staffing crises right now, and we're hearing that a lot from organizations. Hey, we're 5 radiologists down. There is no way we can participate in this. And right now, to be honest, I haven't found an easier way to do it. Improvement takes a commitment. It takes a huge commitment because it is really, really hard to do well. And we're not just talking about making something a little better. We're talking about really redesigning the way that you manage your department, and the way that you interact with your staff and the way that you interact with your work. When we're talking about image quality, there's so many factors that lead up to that the only way to manage it is in a very structured, highly involved process. We haven't found a way to do less. So what we tell organizations is, if you're interested, but you don't have the resources right now, stay involved. We'll keep you up with what's going on. We're publishing a ton of papers right now about the results that we're seeing. So we're making those available to people if they want to read up and see other things that people are doing. And then, of course, if anybody is enthusiastic and willing to commit, we are just 100% in to support them in anything that they need. So, it's kind of like if you're willing, let's go, we'll do it. But it is a huge commitment, and that is a barrier. Absolutely.
Yeah. Okay, great. And then Steve had a question in the chat, which was similar to one that I had. His is, what are the likely targets for additional collaboratives, which kind of tied into a question I had, which is, how did you choose the 4? So how did you choose the 4? And then, so how are you choosing additional ones?
Yeah, so these 4 were global problems in radiology that kind of met the format of what we thought we could improve. So you have to frame a problem in a very specific way in order for it to be able to be improved throughout the program. It has to be specific enough that it has a very clear scope, but not too small that you can use the program in a way that it's most effective. It's a team-based multidisciplinary program. So this process has to cross different roles. And then these are really very high priority for just radiology in general. Lung cancer screening and recommendations follow-up has really come to the forefront of what is necessary and what is needed in radiology, as well as prostate MR image quality. It is evolving and becoming more and more used in clinical decision making, and so there was a real need to hone in on the prioritization of these projects. When we're choosing additional improvement collaboratives, right now we're actually going to take a random projects cohort for the fall. So it's not going to be a collaborative based topic. It's going to be projects from anywhere in radiology. It's a lot harder for us to manage lots of projects like that. So we're kind of thinking about what would that take, because they just need a lot more attention and we don't have as much knowledge about the process. But from there, we're looking to establish probably a pediatric collaborative. That's one thing that's been huge on our mind. We don't have any emphasis on pediatric radiology right now. And then looking for the image quality projects do really, really well in this format. And so we're looking for other image quality type projects for the future.
Great. I think there was a couple other, I don't know if we'll have time for both, but so another question was, where does the baseline data come from? I think in the run charts that you were showing.
Yeah, the organizations have to collect their own data. So we said we pick a starting point of when they're going to start collecting baseline data. For mammo and prostate, it's weekly image audits. So mammo audits 60 images a week and prostate audits 30 images a week, and they have to score them on the criteria, and then that part becomes part of their baseline measure. And then they do that weekly throughout the course of the program.
Great. I think there was one other from Ashley. If you're still there, I don't know if you want to ask it because I'm not entirely sure, but is this applying for new projects or projects that are already in the queue? But perhaps this slide might be answering that, in that people are applying now for future collaborative participation. I don't know, Ashley, if you're on, if you wanted to ask your question.
Oh yeah, I just wanted to see, because I wasn't too familiar with the meeting and what it all entailed. But yeah, I just wanted to know if there's already projects that are in queue, or is there a way to apply a new project idea?
So for the collaboratives, we take, it's a synchronized program, so you have to participate when the next cycle comes up. And so we're taking applications for the 4 established collaboratives right now. So if somebody wants to do a random project, we are, like I said, going to be testing a random project cohort, but it's only going to be about 3 or 4 projects from organizations that we've selected. We hope in the future, after 2024, if this works out well, that we can open that up to other radiology departments to participate and bring their own projects in, so that if you're not interested in one of the 4 collaboratives, or you have another interest in your organization that you want to focus on, that we can support improvement across the board.
Okay, so it's
we have 2 applications.
Sorry.
Right now it's only for radiology. Yeah, so we're working through the American College of Radiology. So we're focusing on primarily supporting radiology departments.
Okay. Thank you.
You're welcome.
Brings us exactly to time. So perfect. Well done. Thank you so much, Kandice. It was really a great presentation and lots of great questions. Thank you all for joining. And remember, July 11th is our next presentation, and you can register now for the Lean conference. So thanks everyone for coming, and have a great rest of your day. Thank you, Kandice.
Thank you.